Okay, doctors, welcome. Let's get me set up. I'm going to share my screen and let's get to this and this. Okay, doctors. First of all, welcome to tonight's program on the importance of cervical assessments in a mild traumatic brain injury. I'm going to make some pretty bold comments here. This is something that This is probably the most important aspect in the mild traumatic brain injury space. And I wanted to do a program on tonight. Your neurologists don't understand this. Your orthopedists don't understand this. Your medical specialists don't understand this. 95% of the chiropractors don't understand this. And if they do understand it, they don't know how to position themselves. And that's what I want to do tonight for you. You may be an attorney listening to this tonight. You may be a chiropractor listening to this tonight. You may be an orthopedic surgeon listening to this tonight. You may be a neurologist listening tonight. You're going to get something out of this. This is the most important aspect of the mild traumatic brain injury space, because this is where people need to go when they can't get help. This is what you need to understand when you're working a mild traumatic brain injury up. Now, me as a doctor in the injury space, in the spinal injury space, I've always been hesitant about the mild traumatic brain injury space because I didn't want to focus on the brain injury. Now, I think for those of you out there, it's important to do that. It is. But what I'm going to tell you and what I hopefully am going to empower you to think with tonight is you can be a key player, a key doctor in the mild traumatic brain injury space, whether you know much about MTBIs or not. Now, the absolute key that we're going to go over tonight is standardized spinal injury workups. I'm going to show you a cervical profile. That profile that I'm going to show you tonight, and I'm going to talk a little bit, as I go, I'll explain it to you more. What I'm going to share with you tonight is some super high level stuff. Okay, this is stuff that a lot of doctors just don't understand, and so they don't take advantage of it in the market. But I want to show you how to do that. My goal has always been to standardize spinal injury workups. Now, what I'm going to show you tonight is standardized spinal injury workup. Standardized spinal injury workup should be taught in every college in the country. They're not. Nobody's learned a standardized spinal injury workup. That's why the cervical profile in the mild traumatic brain injury space is so mysterious. Okay, tonight I'm going to make it so it's not mysterious for you. So one of the things that I want this to start to impact on you is how understanding how valuable you are in the market can help you to stand out in the market. The best doctors in the injury space should be getting the majority of patients. They should be treating the majority of patients because they give the patients the highest opportunity for a full recovery. So what I'm going to be talking to you about tonight, high-level chiropractors understand and they're applying. And I'm also going to give you I'll give you a testimonial story tonight that you've all probably already heard about. But you haven't known how this applies to you. So what I want to do is start to tie this information together. By the way, what you're looking at right here on the screen is the only injuries possible to the spine in a spinal injury case. Now, I know that may sound a little bit different, but the spine only has two tissues. It's just bone and connective tissue. When the spinal support ligaments are damaged, they cause excessive motion. That excessive motion causes nerve interference and focal neurological deficits. Now, focal neurological deficits is key in the mild traumatic brain injury space because the majority of the symptoms are focal neurological deficits. So when you know what causes focal neurological deficits, you know where to look, right? So spinal support ligament damage, disc fracture, those are what can happen in a injury state or an injury case. Now I'm going to present material tonight. You're going to get to ask me all the questions you want to when we're done. Tonight I'm going to show you what these doctors know. Now, I trained over 500 what I'll call smart injury doctors in the United States. Over 500 doctors now have gone through some form of my program. The new program that we have currently is like state of the art. Okay, I'm going to show you tonight what they understand. I'm going to show you tonight what they can do. I'm going to show you tonight how valuable they are in the mild traumatic brain injury space, especially if a patient wants a physical recovery and they don't want to have the symptoms forever. Okay, now you can take notes. You cannot record this presentation and you cannot share this presentation anywhere. There's no recording allowed. So you can take notes. You can ask me questions at the end. But you cannot share this presentation anywhere. Okay, now what these chiropractors know is that a technique evaluation is not an injury assessment. It's very important. There are, I don't know, 113 different techniques. These are the techniques in chiropractic. If you're a chiropractor right now, you're going to spot your technique in here somewhere. Okay, now one of these techniques is an injury evaluation. Now, it is an evaluation for things that could be improved around injuries that could make their injury recovery better. I'm not saying that, but it's not an injury evaluation. None of them. And it's very confusing to lawyers. It's very confusing to insurers. It's very confusing to everybody in the market. This very thing that I just said, especially in the injury space. It's not an injury evaluation. Okay? Now, we're going to start to dive into why you came here tonight. Why you came here was the cervical profile or the cervical assessment. So we're going to start to dive into it because this cervical assessment, again, is what you're looking at on the screen. Now, if you don't recognize it, that's fine. But this is what you're looking at. All right. So let's start with just what is if we go, let's define a traumatic brain injury. Right. So this is the American Congress of Rehabilitation Medicine. This is their definition. It says a patient with mild traumatic brain injury is a person who had a traumatically induced physiological disruption of brain function as manifested by one of the following. Okay, they lost consciousness. They lost memory of events immediately before an accident. They had any alteration in mental state at the time of the accident. Let me tell you, just about everybody that goes into an accident has an altered mental state. They feel dazed. They feel disoriented. They feel confused. They almost always do. In any accident, I've been in 6 of them. I've felt that. Right? Now, here's a key. Focal neurological deficits that may or may not be transient. We're going to really make sure you understand what that is because you are experts at this right now. But you don't know. A lot of doctors that I talk to don't know you're experts at it because you're not sure what a focal neurological deficit is. So let's define it. A focal neurological deficit is a problem. This is just a simple Google search with a nerve. Chiropractors are nerve specialists, right? Misalignment of the vertebra causing nerve interference. Intersegmental somatic dysfunction, if that's what you want to call it, that somatic dysfunction has a neurological effect. It's a problem with the nerve, the cord, or brain function. Very important. Is a headache considered a neurological deficit? Focal neurological deficit. Yes, headache syndromes can be associated with focal neurological symptoms or signs. So we got these focal neurological deficits. We also have loss of consciousness of up to 30 minutes or less. After 30 minutes, we get a different type scoring, post-traumatic amnesia for 24 hours or more. These are more intense type cases. So if we look at the symptoms, same national company, right? These are the symptoms: nausea, vomiting, dizziness, headache, blurred vision, sleep disturbance, quickness of fatigue, lethargy, or other sensory loss that cannot be accounted for by peripheral injury or other causes. So what's a peripheral injury to a brain injury? Anything that's outside the brain injury. So a peripheral injury is an injury that's outside of the main injury site. Now I'm going to tell you there's 2 injury sites. There's the brain injury, and then there's the spinal injury. So they're 2 separate things. The brain injury is a little bit harder to prove. The spinal injury is easy to prove, and it's easy to show. So this is what we're going to focus on. Now, they could also have cognitive deficits, including attention, concentration, perception, memory, speech, language, behavioral changes. They can be irritable. That's what a mild traumatic brain injury is. Now, no matter where you study, no matter what you go through, you're going to see these 6 trajectories. You could take the top TBI educational process in the country, be with the elites that study this. And what they're going to study is what are called different clinical trajectories, pathways, expressions of this condition. You're going to have vestibular, right? Balance difficulties. You're going to have ocular, visual difficulties. You're going to have cognitive function lowering. I feel foggy. I feel brain fog. I don't feel all there. I don't feel myself. I seem slower. My memory seems to be not as good as it was. You're going to have fatigue. You're going to have anxiety or mood. I'm going to tell you, anxiety and mood is definitely going to increase if you can't find a doctor that understands the condition that you have. You're definitely going to have, you're going to be moody, irritable, because your symptoms are not going to abate. You could have post-traumatic migraine headaches. Okay. And you can have the cervical profile. What the hell is a cervical profile? It's in every single one. There's not a program in the country that doesn't teach these trajectories. Only problem is no one understands this one. I want you to understand this one because it's the key one. It's the most important one, especially if you want somebody to recover. Okay. It's also important when you're working it up in the injury case itself. All right. Now, I don't want you to get too into the screen. I just pulled, if you go out and put mild traumatic brain injuries and you pull up images, I just grabbed an image off the internet, right? Now, the leading cause of TBI are these areas here: falls, assaults, motor vehicle accidents, struck by or against. We're going to put sports-related injuries in there. Could be in falls, could be struck by against. Okay, so when it says here, the concussions are characteristic by diverse symptoms and impairments. Okay, impairment is a loss of use of, or a derangement. That's an injury. Loss. I lost my arm, got cut off. Okay, I lost the use of my arm, nerve to my arm, got cut. I can't use my arm anymore. All these are injuries. Or derangement of any body part. Derangement of a body part is an injury. If I were to bite you tonight, and I left teeth marks in your arm, there's a derangement in your skin. If I bite hard enough, there might be a derangement in the muscle. If I bite in the right spot, there might be a derangement in the tendon. Okay, it's a derangement. Derangement to upset the normal position, form, and function of the body part. That's what an impairment is. Okay, what's an impairment that causes mood? What's the physical thing that causes mood? It's an undiagnosed physical condition. What is the thing that causes cognitive dysfunction? Same thing. So when we look, if you're in the mild traumatic brain injury space right now, if you're rehabbing patients, okay, if you're the physical therapy center that's going to rehab the concussion patient, what you're doing is exercise. Your main thing is cardiovascular exercise. That's the main treatment. Exercise for anxiety, exercise for vestibular, exercise for cognitive, exercise for post-traumatic, exercise for cervical. Exercise of what? Look at what's listed here. Manual therapy. What does that mean? Injections, acupuncture. Okay, where do you fit in here? I'm going to tell you tonight, you can be the leader of this. Okay, this is the easiest space. Again, the easiest space in the injury space is the spinal ligament, the non-disc ligament space. That's the easiest space to get into. There is no competition in that space. Not enough doctors understand it. So there's virtually no competition in it. That's what my smart injury doctors understand. And that's where they become well-versed. Now, every 21 seconds, there's a mild traumatic brain injury. Every 7 seconds, there's an auto accident. Okay, so when we look at this, let's start to bring this home. I'm going to start to bring this home a little bit. Now, some of you have heard of Jim McMahon's story. Jim McMahon was a NFL football player, played in the 80s for the Bears, has chronic concussion and now CTE, chronic traumatic encephalopathy. Encephalopathy is a head or brain condition. That's chronic. So if you have chronic concussions, you get the title of CTE. That's what the NFL is suing, and that's what everybody's talking about. So let's listen to what he says. Now he says this on 30 for 30. It's an ESPN Sports.
Bad headaches, pressure on my skull. I couldn't see very well. I couldn't talk very well. All I wanted to do was lay down. My head was just constantly pounding. The pain had gotten so bad where if I had had a gun, I wouldn't have been here.
Okay, so that's his symptoms. That's now he had other symptoms. He had other things as well. Now, what's his next thing? His next thing is he had doctors reach out to him. If I was in a clinical space today practicing, I would have reached out to him. Okay, I'm a diversified adjuster, always have been. I also did Pedibond adjusting. I would have reached out to him because I understand the cervical profile and I understand the most problematic thing that he was probably facing to get rid of his condition. Now, the doctor that he went to was a chiropractor named Scott Rosa, and they did very sophisticated imaging, but listen to what he said.
And these two doctors from New York called me and said, hey, we think we can help you. We think we know what's going on. I said, let's do it.
Now, this guy had early dementia. He was diagnosed with early dementia, which if you have CTE or chronic concussion syndrome, your Parkinson's, Alzheimer's, tremors, all kinds of conditions are right around the corner. Okay, so this is the next thing that he's saying. Now, I want you to focus on what ESPN says is the cause of his CTE. Listen to this. This was very controversial when it took a lot for them to actually put this on air.
While most concussion studies are focused on the brain, McMahon's team traces the effects of CTE directly to the upper spine, having found that neck misalignment can block the flow of spinal fluid and pull toxic proteins directly onto the brain.
Okay, what's a neck misalignment? It used to be called a subluxation. You could call it a spinal instability. You could call it intersegmental somatic dysfunction. Call it whatever the hell you want to, right? That's what was found. Now, listen to what he says. Now,
most times when you're having head problems, that's all they look at is the head. These guys were smart enough to at least look below the head at the neck and see if there was a problem somewhere. They found my problem. They're not going to be able to reverse the damage. Like I said, that stuff was sitting in there for 20 years.
Okay. So the topic of tonight's talk was a cervical assessment. These guys were smart enough to know that you don't just look at the head, you got to look below at the neck. Now, that's if you want to recover. Jim McMahon made an incredible recovery. Now, he also talks about, is this condition permanent? Yes. Are you going to fix a permanent condition? No. Are you going to be able to change the symptoms associated with that permanent condition? Yes, very definitely. Okay, that's what my smart injury doctors scattered throughout the United States understand exactly what I'm talking about here, because they would be the ones that would say, oh my gosh, we got to look for the cervical condition. They know that the main cause of chronic pain is headaches, neck and back. Low back, number 1, neck, number 4, headaches, number 6. Some headache research today says number 2 or number 3. They know exactly what they're looking for. That's why they're so valuable to injury patients and to chronic pain patients. And especially if you have a mild traumatic injury patient who's not abating in their symptoms.
Most times when you're...
All right. Now, so what does he get?
McMahon regularly receives targeted adjustments, clearing the blockage and restoring the flow of spinal fluid.
First time they did this procedure, within 2 minutes, it was like the toilet flush. I could feel this stuff actually leaving my brain. My eyes cleared up, my speech cleared up.
Okay, his eyes cleared up. Is that a focal neurological deficit? Yes. His speech cleared up. Is that a focal neurological deficit? Yes. Pain cleared up. Okay, now you may think that, thank God, this person, this human being found a doctor. I don't think I could be that doctor. Hopefully I'm going to start to change your understanding tonight. You can be that doctor. And in a lot of cases, you may be being that doctor currently in your market and not know it.
McMahon,
So what does he receive? He's going to explain how you can't fix this problem, but listen to what he says.
What damage it's done, it's done. I can't reverse that. But what these guys do for me, they keep me from having these bad pains, having these suicidal thoughts, having me function fairly normally while I can.
Good. So suicidal thoughts, bad thoughts. Is that anxiety and mood problems? Yes. Is that an improvement? Yes. Okay. What is he talking about there? He's talking about supportive care. It's the best example of supportive care I can show you. Got a permanent condition. He receives regular adjustments in order to maintain or support his condition. That's what supportive care is. Now, I'm talking about mild traumatic brain injuries. I could be talking about your tomorrow morning auto PI case. No different. No different. Right? Now, here's the thing. This is what research says. Now, I could pull up other research to show you the horrific. Well, let me just state, while most individuals recover from a single concussion, up to a third of those will continue to suffer from the residual effects, such as headache, neck pain, dizziness, and memory problems 1 year after the injury. And Jim McMahon's, it was 20 years after the injury, 30 years after the injury. Okay, I could pull up other statistics. You can too. Google search. And you're going to see in the top circles in the mild traumatic brain injury space, they know that people do not clear out. If they don't clear out, and you start to look at those and the residual effects, they're not clearing out after 30 days. They're not clearing out after 60 days. They got a chronic concussion case. Now, what they don't understand is they have got a chronic concussion case that has a cervical injury, that has a provider that doesn't understand what to do with it. That's what they really have. Okay, so it says such symptoms characterize a disorder known as post-concussive syndrome and are much like those of whiplash-associated disorders. Both disorders are likely due to cervical instability. Cervical instability is when you have an excessive motion in the cervical spine that causes some sort of nerve interference or a focal neurological deficit. That's all a spinal instability is. A spinal subluxation is a misalignment or mismotion in a vertebral that causes a focal neurological deficit. The technique things that I showed you before, those are technique assessments. They're all different. Okay, so now what is the main problem? The main problem, so when they say, hey, these people suffer, what's the number one thing they suffer with? Headaches. Oh my God, the easiest thing in the world to clear out. Now, when we say cervical instability, I want you to look at this. This excessive motion causing focal neurological deficit can cause visual disturbances. That's what he talked about. Balance difficulty. Oh, here's our profiles. Look at our profiles. We got visual, we got balance, we got cognitive, we got migraine headache, we got the cervical profile right here. And when we don't have anybody that can help us, we're going to have anxiety and mood disorders. Those are the 6 trajectories of a mild traumatic brain injury. I just made mild traumatic brain injuries so infinitesimally simple. Okay, now, can you clear this out? Headaches, imbalance, dizziness, fatigue, nausea. This is the number. So if I do a simple Google search and say, hey, how's chiropractic? Can chiropractic adjustments improve brain function? Wow, lo and behold, looks like they can. How about, are they effective with migraine headaches? Oh my gosh, looks like they're pretty good with it, right? So I could pull up any disorder in that mild traumatic brain injury space. Now, why? because you're addressing a spinal instability, a spinal subluxation, intersegmental somatic dysfunction. I don't care what you call it. Matter of fact, I think it's ridiculous that we spend so much time on the names. It doesn't, in the injury space, it doesn't matter. The names don't matter. That's some profession splitting conversations that make the profession weak, really weak. And it really, if I was the physical therapy profession, I would be like, guys, please keep having those conversations because we want to take your market share. We don't have those conversations. We're not interested in those conversations. So yes, you can treat it. Now, here's the thing. I'm going to take you back up to a slide because there's one point I missed. In all of the really intense circles, the Harvard circles, the Yale circles, they start to say, hey, the problem with these clinical profiles is we're so confused in here that they often overlap. So look at how they say, hey, and anxiety and mood gets into vestibular. Ocular is on its own. Anxiety and mood and vestibular and post-traumatic migraine, they seem to couple together. And we could even set up new terminology and we can say these are different individual trajectory pods. And I can develop a whole science around this. Look what they actually do. When they talk about this overlap, look at the overlap, look at the one that's missing here. Okay, look at where it should be. It's the foundation. It's the foundation. Post-traumatic migraine headaches. Or if I look at ocular, right? Ocular is not going to cause a cervical problem. Balance unto itself is not going to cause a cervical problem. A cervical problem can cause any of these. It's the most important aspect in the mild traumatic brain injury. Now, if you don't understand that, then what you do understand is your minimization in the market, being minimized in the market. In the trauma market, you're going to be minimized. Okay, you have the keys, you have golden ticket, but if you don't know you have the golden ticket, if Dorothy didn't know she had the power of the red slippers, she couldn't get home. So she spent a lot of time searching and going through trauma and scare and fear. That's modern practice today, building a practice, okay? But if you don't know you have the red slippers and you don't know you have the power of the red slippers, it's not as good as it could be. So what I'm talking about tonight is giving you back some of the power of the red slippers, right? So you're not minimized in the market. This is the most important aspect of this market. If you don't think that's true, you are minimizing yourself. Okay, so one of the things that should be starting to hit in here is, hey, there's no one in the space. I'm going to tell you there's no one in the space, but there's no one really in the spinal ligament injury space that really goes after that aspect, the non-disc ligament injury, the severe injuries that are not picked up on MRI. The severe injuries that are not picked up on MRI and can be surgical. In other words, they're so severe, they're surgical, but it's not picked up on MRI, right? This would be a very easy aspect of the injury space to take over as a leading expert. Hopefully I'm getting you to start to think about that a little bit. Now, when we talk about these injuries to ligaments, let me just do a very quick slide that says, hey, we got these red ligaments. In my training, I talk about the red ligaments because we color them red. All the spinal support ligaments are red. The disc ligament is blue, right? So there's a heck of a lot more red to have a problem with than the blue. I'd rather specialize in this and this. In an injury state, if all I have is this, all I have is a disc herniation, it's a pre-existing condition, generally considered to be such, because I don't have the other damage that would be consistent with a fresh injury. So how do I pick this up? Well, it's picked up on your x-ray. It's picked up on your x-ray study, but you cannot minimize this. You cannot shortcut this. You cannot act in an unprofessional way in this area. And one of the ways of acting in sort of an unprofessional way is not to fully understand it, but to use it. Right? So the more, now I guess let me take that back and say a more professional way. I'm not trying to call anybody unprofessional, or say that you're unprofessional or anything else. But the more that you understand this, the more professional you are perceived and appear. And that appearance and perception in the market is gold. All right. So we got to have x-rays and we got to have a specialized procedure for it. Now, how it works is the doctor does the consult with the patient, right? This is your injury patient tomorrow. They're coming in. Oh, I got headaches. Good. I had some loss of consciousness. I had no loss of consciousness. I was disoriented. Matter of fact, I'm a little hesitant to get back into the car. I'm kind of foggy. I got my neck hurts, my shoulder hurts, my lower neck hurts. My vision seemed to be a little bit touchy. I didn't sleep well last night. If this is what you're running into all day long, right? So what are you going to do? You're going to take x-rays. You're going to get those x-rays sent out for an unbiased third party. This year in 2024, this is going to be really important because in this space, spinal kinetics will help to clean up the crappy stuff that's in the space right now. And there's some pretty crappy stuff that passes off for an excessive motion testing. That's not accurate, full of flaws, right? So what I want to talk about right now, next, to transition, we're still talking about the mild traumatic brain injury, we're talking about the cervical profile, is I'm going to run it into mainstream. Your rationale for taking x-rays, all your national associations, most of your guidelines use the criteria of Nexus. Nexus is the national. Let me get out of here. Just trying to move my picture around. National Emergency X-ray Utilization Study. It's called Nexus. There's also a thing called the Canadian Spine Rule. It says this: if a patient comes in and they have midline cervical tenderness, they should be x-rayed. It says, gosh, if we have a painful, distracting injury. Okay, what the hell is a painful, distracting injury? There's two forms of it, right? If you're in a car accident and the engine comes over your right leg and cuts it off. Okay, pretty bad accident, right? You just got your leg cut off. It's bleeding. That's a very distracting injury. If you experience it yourself, you're going to realize your attention goes just to that injury. You could have other major injuries, but you're not feeling that at all. Not at all. Okay, so the second painful, distracting injury is this. Fractures and soft tissue injuries were the most common distracting injuries in the patients undergoing spine radiography. Okay, well, what is an excessive motion injury due to the spinal ligament a distraction injury? 100%. Is a disc herniation a distraction injury? 100%. Is a fracture a distraction injury? 100%. What else can you injure in the spine? There's nothing. That's all there is. Okay. So yes, you should x-ray if you have painful, distracting injuries suspected. Okay. If the patient comes in drunk, let's say they come in the emergency room, they're so drunk, they were in an auto accident, they got x-ray them. That's not your offices. Focal neurological deficits, we already talked about. If you have any focal neurological deficits, patient just said they had headaches. Patient just said they gave you a list of symptoms. Those symptoms are caused by focal neurological deficits. You're going to x-ray. Or this one. Look at this one. Oh, let's look at Medscape once. So we go to Medscape and we say, continue. All right. Let me see if I can quickly get in here. Let me see if I can get in here. No, they don't match. Okay. So we're not going to get in there. Let me just give that one more shot. Okay, so we're going to go a different route with this. I'm going to get out of here for just a second. I think it's important for you to look at this. And let me see if I can pull it up. So small. Let's build it up. Okay, cervical sprain. Wow. Visual disturbances, blurred vision, tinnitus, dizziness, concussion, neurological symptoms. It's going to have memory problems, cognitive dysfunction. If you look further into this group, it'll show you that it has also eye problems. Okay, what is this called? Cervical sprain. What's a cervical sprain? Cervical sprain's a ligament injury. Right? So going back to the presentation, let's go back to it. So it's important to understand that that is, that is focal neurological deficits. That's what you're experts in. You're total experts in. But in order to gain more market share, I need to get a lot of you to actually be able to vocalize this expertise, right? And it also, if you have any sort of altered state of consciousness, or you think that there's any sort of encephalopathy, what's encephalopathy? It's a concussion. You got x-ray. But what are you looking for? You're looking for the thing that Jim McMahon finally found. That's what you're looking for. I'll show it to you. I'll show you how to do the workup in just a bit here. So let's review the flow a little bit. Patient comes into your office. They're an injury patient. They're a chronic pain patient. They're a patient that comes in and says, oh my God, I had a concussion 5 months ago. And the problem is I'm still having headaches. Okay, were they in an auto accident? No, maybe it's a school accident. They were in a football injury. They were slip and fell. Doesn't matter. Right now, patient comes in, the patient's going to be imaged. What do they have? They have midline spinal tenderness. They have focal neurological deficits. And I'm thinking that they at some point had a painful, distracting injury. Oh my God, who wouldn't x-ray them? Of course, you're going to x-ray them because you want to understand what's causing it. What I'm showing you is standard flows now. These are standard workups. This should be what's happening in every chiropractor's office throughout the country, like it does in the dental community if you go in for a cavity. Go to any dentist in the world, it's the same workup. These should be the same, right? Now, in the injury state, you take the x-rays, you send the x-rays out for an excessive motion study. That's how you tell how damaged the spinal support ligaments are. You start conservative care. You go into pain management if they need to. You go into surgery if they need to. You actually get the patient resolved. You report what the injuries were. You report the permanency of it. You report the effects of it, and you report the future of it. Guess what that's called? That's called a final narrative report. That's called a final assessment. That's what everyone's looking at. This is, if you want to talk, is this claim value? This is what claim value is. It's just these things. What are the injuries? Are they permanent? What are the effects? And what's the future? That's an injury claim. I don't care what market, Allstate, State Farm, auto owners insurance, work comp, doesn't matter. That's the assessment. That's what somebody's looking at on value. So you take, first of all, if you're going to do a cervical profile or a cervical assessment, you take good x-rays, right? So the x-rays that you're going to take, now I didn't show them all. You can take a Davis series. You can take the obliques, whatever you want to take, but the main area is the stress views, right? So we're going to look at the cervical stress view, right? I don't have to measure this to look and say, okay, I've got an upper cervical. I've got a little bit behind on the upper cervical. I definitely have upper cervical findings. Now, when you're shooting these are the easiest things to shoot. They're not hard to shoot. All you got to do is shoot them, or have your imaging center shoot them. Now, you're going to see we have a positioning guide. Spinal Kinetics has a positioning guide. I'll tell you in the end how you can get a copy of this positioning guide if you want to know better how to shoot these x-rays. Okay, this is what you need to understand to take over that profile, that area in the market. You want to be that doctor that reaches out to somebody like Jim McMahon. You got to take good imaging, or you got to get good imaging. right? I showed a slight example. This is the same in the lumbar spine. Okay, we're not talking about the lumbar spine tonight. We're talking about the cervical spine, but it's the same in the lumbar spine. Now, you want to, especially in the injury space, okay, you want to, oop, there we go, sorry. Okay, sorry, I accidentally hit the pause button. Okay, I'm the CEO of Spinal Kinetics. Spinal Kinetics, in my opinion, is one of the most important companies in the market today. All right, what we use is FDA cleared technology, and we do the excessive motion testing. We also help doctors to seriously increase their professionalism profile, their perception in the market. We're independent, we're bias free. It's done by board certified medical radiologists. We have highly developed AI to assist us. We're insurance friendly. We've been doing it for 13, 14 years now. We're insurance friendly. We use DICOM images. That's a thing that most of the softwares that are out there are not. They're saying that they are, but they're not really using them. They're not importing them like like you would need to in order to do an accurate assessment, right? It takes 5 minutes to upload into our system. We have the reports back usually 12 to 24 hours, says 24 to 48 hours here. In-house, do this by yourself. Perception's lowered. No third-party validation. No one trusts the findings. The insurers don't trust the findings. They see it as a severe bias. There's complicated and risky billing procedures. Some doctors are out there billing for this stuff. That's risk. Now you're in risk land. The provider is wholly responsible for the findings and how the findings of the software are developed. If you own an MRI center, you have to know how the MRI, and you're going to charge for MRIs, you have to know how your MRI system works. If I'm going to charge for excessive motion testing, I have to know the ins and outs of how the software was developed and designed, because I'm now the owner. Do you want to stay away from that? Don't get into that. That's a bad space in the injury space. And I think in 2024, it's going to turn out to be a really bad space. So let's go to the cervical profile. Patient, you did the flexion, you did the extension, you did the A to P open mouth, you send it out to Spinal Kinetics, and it says, hey, we've got a lateral shift of 471 and 3.65. That's significant upper cervical instability, which can cause any one of these symptoms. Any one of these symptoms. Now, if you look below, it says at C2, we have a ratable level of angular finding, 13.5 degrees of difference. That's a severe injury in the upper cervical. So this upper cervical on this patient profile is severe. Now, is it severe enough that you can't treat the patient? No. You're going to you're treating these all day long. You're treating them right now. You just don't know you're treating them. Right? So if we got into, and this is one of the most asked questions, and this is the most confused area for doctors in the spinal injury space, only in the chiropractic market. Can you adjust an instability? If you can't, you could not adjust this patient. And of course, my answer is you have been for your whole careers. Of course you can. You should know why. And you should know what your adjustments are doing in the injury state and why it's improving what it's improving, because then it's easier to communicate and stand out. What I showed you earlier was standing out, getting doctors to stand out. Okay, now, what this report shows is the patient has a grade 3 sprain. The patient is surgical qualified. Now, why are they they're qualified for activity restrictions? They should be under athletic return to play parameters. If they're in a contact sport, they should be reduced in their participation in that contact sport until the ligament injury stabilizes. They've got a 25% whole person impairment. They got a severe facet injury. This is what an angular injury looks like. It severely damages or severely hyperstretches the facet ligament, right? They're qualified for up to 76 visits in a 56-week treatment time. And that's right on the chiropractic guidelines. 100% treatable with chiropractic care. So let's go, let's just look at what I'm talking about. Now, I want you to remember the number 13.5 degrees. Okay, that means that there's a severe angular finding at C2 and C3. Okay, hopefully this link works. Yes. All right. If I go to Spinal Kinetics, and I highly recommend that any of you go to Spinal Kinetics, look, there is so much incredible stuff that we put out on this site. If you go to guidelines, if I go to surgical guidelines, okay, so if we look here on guidelines, we just published a few. Here's the AMA guidelines. It talks about the rating of these injuries. Here's return to play parameter guidelines. Here's Croft treatment guidelines. Here are surgical guidelines. Under the surgical guidelines, if I pull up a snapshot of the cervical guidelines, it says greater than 11 degrees of angulation. We have 13.5. This patient's qualified for a spinal fusion surgery. And my gosh, the only thing I'm hoping for that patient is that they have a doctor that understands that condition and understands what to do with it. Now, if you're hesitant about what to do with it, what would I do with it? You need more training, more education so that that uncertainty is replaced with certainty. That's what we do every day, all day long. When I'm in my smart injury doctors program training doctors, I'm giving them more certainty. I'm helping them become very certain about what they're doing with this. So that's what makes it surgical, right? So this is a really significant workup. Now, I just explained it to you. I've explained how it basically follows all the guidelines in the country. And it's exact. It's very exact. It's very reproducible. It's very standardizable. You can easily standardize it. No problem with it at all. It is the most significant part of the mild traumatic brain injury space. If I want to go out to a neurologist that's now talking about, well, we're in the mild traumatic brain injury space. Man, do I have talking points for that neurologist or the orthopedist or anybody else that's getting into it. If I go out to any MTBI group, the cervical profile is the main profile that they don't have a clue about. They have no idea. Now, I don't minimize that. I don't teach my doctors to talk and minimize it. Why would you minimize it? You're the most important. You're like the sophisticated surgeon that everybody looks up to and goes, oh my God, they're so important. You're so important, but you're not important if you don't know you're important, because if you don't know you're important, you can't assert your importance. Okay? This is every day. Every 7 seconds, somebody's in an auto injury. Every 7 seconds, they need a doctor that can do what I just showed you here. Now, if you think you can't treat a surgical, I just threw this up. Don't get hooked. Likelihood of surgery for work harm. Oh, Dr. Hunk, we're talking about an auto injury, not a work-related injury. The injuries are the same. It doesn't matter where you get it. If I burn you in a car, it's called a car accident. If I burn you at work, it's called a work-related injury. Is the burn the same? The burn is the same. Doesn't matter where you get it. If I burn you at home, it's called a home-related injury. If I burn you in a grocery store while you're shopping, it's called a public place injury. Okay? Now, it says if I went to a chiropractor, good. This is my chance of having surgery. Why? Because I'm stabilizing it without the need for surgery. That's what makes me valuable. That's what makes me unique. Same in the mild traumatic brain injury space. So again, and I'm going to start to wind this down. We'll get into question and answers. You want to stand out. What I just showed you is how you stand out. Now, how you stand out is you start to take this and put it into action. Hearing it just once, a lot of times, is not enough. That's why I have a program called the Smart Injury Doctors Program. And by the way, these doctors use spinal kinetics because they understand what they're doing with spinal kinetics. They're not shortcutting processes because there's too much market share to be gained here. All right. That's why they use the spinal kinetics. That's why, let me play this again.
Most times when you're having head problems, that's all they look at is the head. These guys were smart enough to at least look below the head at the neck and see if there was a problem somewhere. They found my problem. they're not gonna be able to reverse the damage. Like I said, that stuff was sitting in there for 20 years.
Now, hearing what I just said and in action makes you one of the blue people. Okay. You're not going to stand out. Hearing what I said and say, oh my God, how do I apply that? And start applying it makes you gold. Absolute gold in the market. Now, at first, people will treat you like lead. Okay. Because there's so much market noise. So you have to be willing to understand and be certain about what you're doing so you can persist in it. As you persist in it, you will be perceived as gold, but you're not going to persist in it at first and be perceived as gold. Now, in some cases, you'll hit a home run right out of the gate. You'll be perceived as gold. That's not the norm. The norm is you have to start to apply this. You have to start to communicate it out into your market, right? Okay. Now, if you take your cell phone out right now and you hit scan this code, you can pick up a free user positioning guide. You're going to pick up a free report. For those of you that have never seen a report, you're going to pick up a free report from Spinal Kinetics. The positioning guide is really important because a lot of doctors don't know how to shoot the A to P open mouth, or they don't know how to explain it to an imaging center. Now, if I go to an imaging center, just to give you an example, if I need to have an imaging center take my images, I'm going to explain the significance of these images and what I'm doing. And the reason why I'm going to explain that and the reason why I'm going to spend some time is because not only what I showed you, I can go to the chronic a concussion case, the case where the symptoms aren't abating. It's no different than the chronic headache case, no different than the chronic neck pain case, no different than the chronic low back pain case. Okay, when I'm explaining this to the tech, what I need done, I'm making it significant because I know they're connected. They may have headaches. They may have chronic neck pain. The person I'm explaining it to, their mom might, their dad might, their best friend might, their classmates might, their boyfriend might. Okay, these conditions are not the first, fourth, and sixth leading cause. And not, if I could put a pair of glasses on you tomorrow, and all they did was showed chronic neck pain patients, chronic low back pain patients, chronic head patients, everywhere you looked, you would see them. And you would go, oh, how hard is this to grow a practice? Holy smokes. Everybody I'm looking at practically got something that I can help. Okay, but what are you talking about? So you got to start to put this in action. Okay, now what I'm going to do is I want you to take that. It's going to take you out. I'll show you what it's going to take you out to. It's going to take you out to this. It's a page. Put in your name, put in your number. Give us a little bit of information about you. And it's going to take you, you put in the information, and it's going to give you that download. My guys here at Spinal Kinetics work a lot. They work very hard to actually make this information as accessible as possible. We can only do so much. Your work is now required. Okay, so let's get out of there. And I'm going to stop sharing my screen and I'm going to go to Q&A. Isaiah, if you can help me with the Q&A. I know we have chat and okay, for MDs, please explain how manipulation can help stabilize the instability versus patient strengthening. Is it writing areas of hypofunction around the instability? No, doctor, it's not. This is a medical doctor and it's a great question. So when spinal tissue, when spinal ligament tissue is damaged, the tissue has loaded with what are called mechanoreceptors. Mechanoreceptors are little stress receptors that take minute, if I change the position of my neck in any way, there's a pressure, chat's disabled. Okay, Isaiah, somebody said chat is disabled. Let me just hit this answer live. Dr. Kramer, can you hear me? No. Okay, so I'm just going to go back to that answer. The mechanoreceptors are in the ligaments. The mechanoreceptors are not the stabilizing part of the spine. They keep the parts in position, and they're actually not that strong in comparison. What is strong is the muscles around it. So when the ligaments are damaged, that's permanent. Jim McMahon's damage was permanent. What the adjustments do around it is they reestablish the communication of the mechanoreceptors with the neuromuscular control unit, or the communication to the muscle system, so the muscles can resume better function around that instability. Now, any doctor that's adjusted spine patients, you have to understand, I did over 1 million adjustments. I did a lot of spinal adjustments. Okay. Some of you out there have done way more than that. Okay. You know when something's improving function because the patient gets up and says, oh my gosh, that feels better. You know when it's not. Patient goes, oh my God, this feels worse. Right. So it's very easy to determine if your treatment is working. And that's what causes that instability. That's what a chiropractor is doing with that instability all day long. They're adjusting it. Now, the physical therapists don't have the baggage of this. They're being trained just to adjust. They don't have the baggage of it, and they're in some cases they're doing a very good job. But that's what they're doing, right? So if I go to surgical guidelines for this, hey, this instability for evaluation for spinal fusion surgery, most of the guidelines are going to say, hey, we need a 3-month conservative care failure in treatment before we fuse the spine. Okay, so hopefully that answers that question. Isaiah, can you hear me at all? Okay. Okay, great. So how do I, if you can assist me, I don't know if we've got any other questions tonight, or if I can see, how do I see?
If you hit the participants tab, you can see those people who have their hands raised. Andrea Del Monte has her hands raised. If you'd like, I can allow her to talk.
Great, but if I hit the oh, there we go. Now I see it. Attendees. All right. Thank you for doing that. Yeah, go ahead, hit it. Hit it.
The hand went down. So if you still have a question, Andrea, if you re-raise your hand, we can allow you to talk. Otherwise, if not, if that was answered in the last, also great.
Okay, great. So anybody have any questions on the topic that I talked about tonight? Any questions? Usually get a lot of questions. So I either did a really good job tonight or not such a good job tonight, or you don't want to ask questions, you're not sure. This is the most important aspect of the mild traumatic brain injury space, bar none. Now, this is the most important aspect of the space of anybody that wants to recover from a trauma. So it's not just the mild traumatic brain injury space, but of course we position it for the mild traumatic brain injury space tonight. I'm looking at the doctors that we have in here. We have a lot of really good doctors. We have a lot of attorneys. We have attorneys in here. So anyone have any further questions? If you do, just put it in the question, in the Q&A, in the chat, or just simply raise your hand and I will unmute you. By the way, the doctor up in Minnesota, Dr. Kramer, anybody in the Minnesota area, you want to look up Thomas Kramer. He's one of the best medical doctors that also understands this condition. He asked a very good question tonight, but you should hook up with him in his space up in Minneapolis, Minnesota, up in the Minneapolis, Minnesota area. Okay. Anybody else? Any confusions in the space? Any like, okay.
You got a couple, you have a couple questions in the Q&A popping up.
Okay, great. Chat's disabled. Okay, Anthony. Yeah, Anthony, yes. When you say, do you have PowerPoint presentations regarding TBI? Yes, it's in the current one. Come on the coaching calls with me and I'll show you exactly where it is and how you use it. This is an attorney. I need a doctor in Orange County, CA for a client of mine. Any doctor that's on from Orange County, CA needs, and basically what he needs is a doctor that can do what I just said to do. Attorney Shapiro, if you need somebody, call Spinal Kinetics, see if we've got somebody in Orange County. Should be able to help that. This doctor says, please review the effect of the adjustment on the instability. Okay, good. The key question is, always, how does an adjustment improve an instability? Okay, now you have to understand, let me share something with you. I'm going to, in the background, pull it up. It's not as part of tonight's program. Let's see if I can pull it up. Nope. Okay, so when the chiropractic community actually said, hey, we want to be involved with Medicare, it was in the 70s. And when that happened, just looking for something here. When that happened, they put forth 17 or 19 subluxation patterns. Okay, half those patterns were hypermobile, right? So let me see, I did pull something up. I'll share it in just a second. I want to get to what I want to share with you. There's a lot of slides in this thing, but I'll show you what I'm talking about. Okay, so let's go back to Zoom here. Let's go back to screen share. Good. All right. So if we look in the original, what chiropractic profession said it was an expert in, right, was this thing called adjustment position causing nerve interference, call it whatever you want to. And they said, look, you can have static subluxations. And they listed them. These are different ways, and I can go forward in misalignment. It can go backward in misalignment. It can go lateral in misalignment. It can rotate. It can go forward. This is just another way of saying forward. It can go backward. It can alter the interosseous spacing. That means the disc can start to reduce. The foramen can be encroached. These are all static misalignments, right? And then it said, God, what else can we have? We can have kinetic misalignments. That's hypo or hyper or aberrant. Now, what aberrant is, I don't know. It's a hybrid of hyper and hypermobile. All right. This hypermobile was a key component. It's always been a key component. Now, if the chiropractic community cannot address the hypermobile segment, it cannot be in the injury space. Because people like me will come along when your claim is being evaluated and somebody's trying to say that you treated too much or you harmed the patient. Somebody like me is going to come along and say, good, I'm the hired expert. The first thing I'm going to do is an evaluation. I'm going to do an assessment. I'm going to say, look, there was underlying severe ligament damage. You don't have a chance at that point. Now, I can also teach you when you're in that position, how to get out of that position. I know both sides of it. But this hypermobile area is the easiest area. You're working with it daily. If I were to ask you, and everybody on this call can listen, if I were to ask if I were to ask the doctor, a medical doctor, right? If I were to ask Dr. Kramer up in Minnesota, hey, how much do you pay for malpractice insurance? And then I tell him, hey, sure.
Oh, it's pretty cheap for physiatry, believe it or not. I'm about three grand per year.
Okay, that's really cheap.
Yeah.
All right, chiropractors pay anywhere from $500 to $1,200 to $1,500 to $2,000. Okay, it's also very cheap. Now, why is it cheap? Because both are not hurting people, right? So that's the other reason why it's inexpensive. The other thing, there's a thing called manipulation under anesthesia. Okay, people have heard of it. Dr. Kramer, ask you to unmute once. Come back. Yeah, Dr. Kramer, have you heard of manipulation under anesthesia?
Yes.
Good. Do you realize that there is no instability as a contraindication?
You know, I guess I can't say it because I haven't seen much of it. I know it's out there, but I don't see it done very often.
Yeah,
Shoulders a lot, but not much in spine.
Good. So there is no, now the most problematic place the patient could be in an instability, if adjusting an instability is a serious problem, is if they don't have any muscle control. So when they anesthetize the patient is in the most vulnerable position. Look up manipulation under anesthesia. You're not going to see no contraindication for spinal instability. So it's just, these are just, all I'm doing is giving you examples. Now, the reason why you're asking me these questions is these questions are the unresolved questions. These are the questions when I have the answer to these questions and I'm super solid on my answers with these, I'm gold. I stand out. I'm going to be who Dr. Kramer is going to want to work with. If I have a clinic in Minneapolis, we're going to work together because he likes the professionalism and I like his professionalism. So it's actually, that's what really gets it, really makes it a lot of fun. Oh, great. I have a doctor here, Dr. Demonte. I have no questions, just a statement for anyone on the fence. Don't doubt joining this group. All right. Now, this group, what she's talking about is smart injury doctors. I was not doing a smart injury doctors presentation tonight. If you want more information about my training program, you go to smartinjurydoctors.com and just get in touch with us. Wasn't the purpose for tonight. Person says here, why not thoracic? Thoracic, why not thoracic for the mild traumatic brain injury? Is that the question? Let me see if I can get you.
I think he's referring to why doesn't spinal kinetics image the thoracic, or why don't people do imaging on the thoracic?
Excessive
Because he
motion.
says, please create it for the ribs and thoracic.
Yeah, it's almost impossible. You can't get imaging good enough, and no one can actually do a great excessive motion study in the thoracic spine. There's too much, the ribs are in the way. It's too hard to get the right shots, and there is no real way to do that. No one does it. So it's not just spinal kinetics would do it. If somebody else pioneered it and showed us how to do it and showed us a great way to do it, I'm sure we'd add it. But no one does it. No for CRMA. I don't know what number for CRMA. I don't know what that means. Dr. Schultz, if you wanted to ask a question, I don't know how to respond to that. Okay. Please review the effect of the adjustment on instability. Okay, good. Ligaments are damaged. When the ligaments are damaged, okay. Let me see if I can pull up one other thing. There's another slide that might be helpful for you that are asking this question. And I'm just going to look. This is in a totally separate slide deck, and I'm just going to look for something very, very quickly. If I can't find it, I'm just going to verbally explain it. And again, I guess in the future, we should have maybe have a talk just on that. I know I talk about it a lot. It is a question that I would ask a chiropractor under deposition. If I was a defense attorney, and if you're going to tell me that you do diversified adjusting and you're specific, sorry, it's not happening. You're not specific. No, I'm not specific. No one's specific. Okay, here's the slide I'm looking for. Okay, so let's talk about what is known. Okay, so if we look at this slide, right, we're going to look at it and we're going to say, here's what happens. When we injure mechanoreceptors, we lose the neuromuscular control unit and we have corrupted muscle response patterns, whether it's the multifidus or any other muscle. Okay, now what that leads to is higher facet loads. Why? Because there's more stress going to the spine. Does that cause irritation to the already irritated facet? Yes. Can that go chronic? Yes. Can that cause muscle fatigue? Yes. Can that cause higher stresses and strains on the already damaged ligaments? Yes. Can we get tissue inflammation? Yes. Can we get chronic pain from it? Yes. This is what this is. Now the adjustment interrupts this. It interrupts this process because it reestablishes the mechanoreceptors communication with the neuromuscular control unit. The neuromuscular control unit is just the neurology that goes from the mechanoreceptor to the muscle. That's all it is. Subfailure injury of ligaments. You want to look up, if you're a chiropractor, you want to go to dynamic chiropractic. Look up subluxation revisited and revised. Okay, and you're going to look, what is a subluxation? It's a subfailure of ligaments. That's what it is. Injured mechanoreceptors send out a corrupted transducer signal to the neuromuscular control, which finds spatial and temporal mismatch between the expected and received. What does that mean? Okay, it means, hey, when I'm bending over to pick up the paper, muscles are supposed to be firing, which means contracting, and other muscles are supposed to be relaxing. Okay, if I got a corrupted signal, I get a corrupted response. So now when I'm bending over to pick up the paper, muscles are firing that shouldn't fire. And I go, oh, God, oh, spasm. You just experienced what I'm just showing you, right? So that's what the adjustments do, is they interrupt that process. All right, we'll stop sharing this. Go back to the Q&A. Matt Schultz, sorry, thank you. Okay, no worries. Robert Haley, we usually taught to adjust fixations, motion, palpation, etc. So you're saying to adjust the hypermobile segment or addressing the hypermobile segments will fix the hypermobile segments. I'm saying you've been doing it your whole career. And I'm saying that the majority of chiropractors, 95% use diversified. You cannot adjust accurately enough to only hit a hypomobile segment. Plus, I'm not aware of any consistent thing that shows the consistent hypermobility. So here's what I'm saying to you. Right now, if every injury patient had a test, watch this. Okay, so it wouldn't matter where the test was sent from. All right, let me get out of here. We went back to my presentation. And we went and we said, good. This patient, whether they came from California, Utah, Iowa, wherever, was sent in, right? We're going to get a read, just like if they went into an MRI center. That read is standard. Okay, that read is standard. Now, we can tell exactly where and how much excessive motion there is. Show me anything where a patient could go into 100 different chiropractic centers and get a reliable, this is where the hypomobility is. Not happening. So yes, we've been taught because it's easy. It's an easy explanation. Something is fixated. Therefore, we got to pop it a whole lot of times to loosen it up, get oil in it, make the door hinge go back and forth better. These are super, super simple explanations, and they work. And I use them myself in private practice. Okay, but it's not the whole story. It's not the whole story. And it's certainly not the whole story in the injury space. Okay, let me give you an example of that. If a person injures their severe ligament injuries to the ankle, okay, and they walk in, got a swelled up ankle. Chiropractor's approach is to adjust that ankle. Now, is the inflammation, if you felt that ankle right away, especially in the acute stage, is it going to feel hyper or hypomobile? It's going to feel hypomobile. 1000%. Is it hypermobile? Yes, but it's got inflammation that's covering the hypomobility, the hypermobility. And I hope that makes sense. The easiest thing I can express to you. Okay, once that inflammation is gone, there's hypermobility. Okay, now why would they actually do adjustments or extremity adjustments for that? They do extremity adjustments for it to realign the components. So as they heal, they optimally heal for optimal function. And in the stretch aspect of the ligament itself, there's value, there's therapeutic value to that stretch, bringing back in the mechanoreceptors to reorganize and to communicate better with the neuromuscular control system in their area. Right. So I know that I talk about it because I'm in the injury space, It's too bad this isn't taught, but there is no injury work taught in any chiropractic college, any medical college. There's no formalized curriculum. Dr. Kramer, any of the medical doctors that are on tonight, they didn't have a formalized curriculum in medical school on spinal injuries. No chiropractors had it. No physical therapists had it, and no DO has had it. So you have to get it outside. But it has to make sense. It didn't make sense to me until 1995 when they started testing patients. I was like, okay, look, I got severe alteration motion segment integrity findings. I was adjusting them. Had no problem adjusting them. No hesitation, no back off, nothing, right? Maybe it was because of ignorance. Maybe I was too ignorant to know. I wasn't educated enough to know. But I can tell you one thing, I was getting damn good results. And that's all I needed to know. What are my results? And then how do I explain what I'm doing? If I take, let's say I do 35 visits on a patient that has this profile that I showed you tonight, C2, remember I said it was surgical. Let's say I stabilize that in 35 visits. Okay, I just stabled a surgical patient in 35 visits. So anybody in the country wants to say, oh my gosh, you overtreated. Oh my gosh, you're not a good chiropractor. I'm like, damn, I'm one of the best in the market, right? I also cleared out the symptoms that would be considered the mild traumatic brain injury, whether I worked it up or not. Because I understand the cervical, I understand the injury. I understand what I'm doing with those injuries. Okay, great questions too, by the way, doctors. I really appreciate the questions. With that in mind, when is it time to add strengthening? It's time to add strengthening in. You want to get strengthening in as early as possible, as long as it's not irritative. So Dr. Kramer is the doctor asking the question, who's done incredible rehab, used Menix equipment, used stuff in Minnesota that was state-of-the-art equipment, right? I used a lot of Menix in my private practice. I didn't use it in my private practice. I referred out to a physical therapy center that had it. So as soon as the patient was stable enough to exercise, where the exercise was not causing minor exacerbations in the condition and therefore retarding their recovery. Each patient is different. Some patients you can almost go right away. Some patients you might have to wait a month. Some patients 2 months. So it just depends on the patient, because here's the thing, doctors, the injuries are the same. The injuries are the same. That's why they're so easy to work up. The condition is the same. The condition, if a burn patient walks into a medical doctor's office or a chiropractor's office or the vet, if I badly burned my forearm and I walk into any one of those, the burn is the same. Doesn't matter whose office I show up in. A spinal injury is the same, no matter whose office that it walks into. The thing that's different is the person that has the injury. They're all different, and they have all different features and factors. Some are obese, some are not obese, some are super healthy, some have had a history of a lot of trauma, some have had no history of trauma. So they're all different. They have comorbidities, some have high blood pressure, some have breathing problems, some have all kinds of other things. So the patient that has the injury is all different. The injury itself is the same. So good question. Great questions. Okay. Isaiah, you picking up anything else? Doctors, I highly recommend, and I'm just going to make this statement, if you're not using spinal kinetics in the injury space, use spinal kinetics. Call, get an account, download the information, start testing. As you start testing, you're going to see unbelievable amounts of injuries. If you test with, I'm going to tell you right now, if you test with some of the softwares that are out there, you are far over it. They're overreading. Some of them are unbelievably overreading. And it's because the process of bringing the images in, the process of the measurement system that they're using is flawed. Like I can just look, I've been doing this since 1995 now. I'm the oldest in the space. I've created more systems than anyone in the space. I can just look at reports and I can go, okay, it's not even close. And I've seen some stuff that is really, really bad. And I see the doctors billing for this stuff. And the only reason why anyone gets away with that is because there's not a lot of doctors. When I said stand out, there's not a lot of doctors in this space that really understand it. If you have one that really understands it and you're using some of these systems, good luck. Okay, because I think you're just setting yourself up for opportunities for things that you don't want to be set up for. You want to use an outside, independent, unbiased, third-party source. I'm going to do that. I did it all the time in my private practice. I sleep very well at night. The injury practice is a very, injuries field is a very regulated field. You can make insurers unhappy. You can make people unhappy. So that's my advice. So get on board with Spinal Kinetics. If you're in the injury space, get on board with this. If you want to know more information about how do I present to attorneys, or how do I present to medical doctors, or how do I increase doctors' confidence in this space, look into smart injury doctors. It's a super inexpensive program, comes with coaching, comes with video training, comes with a lot of different things, comes with marketing materials. And so look for that. All right. Isaiah, you seeing anything else that we have? Doctors, first of all, I appreciate we have the majority of you are still on, so I appreciate your time, your attention always. When I do programs like this, I'm going to try to bring value. There's no you don't get a replay of this. If you're a smart injury doctor, yes, it'll be in the bonus section, because I think this is an important enough topic to be in the bonus section, because the more you see this, the more you're going to understand your value in it. So doctors, thank you very much for taking the time, giving me your attention tonight. I really, really appreciate what you do. I'm trying to make it easier for you to be noticed in the market and to do what you do, and to make it easier, because if you're really good at what you do, you should be loaded and life should be easy or easier for you. And that's what we're trying to do when we bring forward these topics. So thank you very much and have a good night.